Okay, let's see. Okay, can you see my screen?
Yeah, I see your Osiris database. So
Oh, whoops.
yeah, it's yeah. With the GoToMeeting update, you have to like pick which window you want it to show.
Okay.
Now we see a
Okay.
Steve.
Okay. Yeah, just a few cases this week. This one is a case that kind of surprised me in looking at this. You can see that this is um, this is about a 78-year-old woman with this CT with chronic shortness of breath, and you can see what looks like upper lip predominant emphysema, some architectural distortion as you go down the lungs here. You have more areas that look like paraseptal emphysema in here and central lobular emphysema. The fissures are a little bit distorted as we're coming down. You can see some ground glass opacity in the lower lobes with some traction bronchiectasis and bronchiectasis that gets worse at the lower lungs. And very little fissural nodularity or anything else here. I can tell you that this patient has no history of smoking, is a non-smoker. And you notice that, and no significant secondhand smoke exposure either. And you notice that there's a biopsy, a wedge biopsy site here, and also in the middle lobe and lower lobe. And this actually was biopsied, and this is all, let me show you the mediastinum, just a few lymph nodes here. But this is all sarcoidosis. Sarcoidosis was all that was found with some emphysematous spaces on the pathology. But this really shocked me. I guess I've never seen a case of sarcoidosis present with what looks like emphysema, almost entirely like emphysema, with some architectural distortion. I just wanted to get some input from other people. Have you seen this type of presentation of sarcoid?
Brent, so I've seen two cases of sarcoid where the only manifestation was paraseptal emphysema, but
Wow.
but not like this. I mean, you have central lobular emphysema, you have findings of fibrosis. So the answer is not like your case. And it may have been they had paraseptal emphysema and they happen to have sarcoid with just, lung findings that we couldn't see.
Yeah, I mean, to my knowledge, there's no alpha-1 antitrypsin deficiency or other cause for emphysema in a non-smoker, and definitely a non-smoker, or at least denies any history whatsoever of smoking or secondhand smoke. So I was just shocked by this case.
This is Howard here. Sorry, I just joined a moment ago, so I may have missed something. But does this patient, was the diagnosis made by the open lung biopsy?
Yes, the diagnosis was made by open lung biopsy, non-rectizing granulomas, and there was, again, no history of smoking and no secondhand smoke exposure that we know of, and no other contributory factors here that we know of.
And they didn't describe any other pathology that you know of on the open lung biopsy, like cystic disease or anything else?
No, they described emphysema and some architectural distortion with some fibrosis, and then non-necrotizing granulomas. So,
because the cystic disease is a little bit odd. I've seen one case that actually turned out to be amyloid, in which there was a granulomatous response ostensibly to the amyloid. So it wasn't actually the granulomas of sarcoid, but just a granulomatous response to another pathology. So always keep that in mind, that they may see granulomas, but it might be a granulomatous response to some other pathology that's the actual pathology, primary pathology. Because this is curious, right? Yeah.
Yeah, it's interesting because to my eye, most of this looks like true emphysema. Maybe a few cysts scattered in here, but you see some central dots here and kind of loss of the lobular architecture that looks, like emphysema. And I guess I didn't even read. I read this as this is would be a very atypical appearance for sarcoidosis. So I was just shocked that first of all this is a non-smoker, and second of all about the diagnosis. So. But yeah, maybe it's something else that is just giving granulomas, but that was it wasn't even a hedge in the pathology. So
Okay.
Brent, did they specify in the pathology report sort of the location of the granulomas? Mark Schiebler is asking, is it were they airway centered? Were they more on the the periphery of the lobule, or they just describe granulomas and not specify?
They just, as I remember, they just described granulomas. I'll get the official report and next week, and I'll paste it in. So I'll bring it. So. But as in a chronic HP or something like that, or
else, is it more airway? Because this looks like a lot of airway issues.
Yeah, does not look like sarcoid at all.
No.
So. Okay, I just wanted to follow up on this case. This was a case I'd shown last week. Let me make sure you can see the screen here. Let's see. Can you see my MR now?
Not yet.
Okay.
I think you have to select the image, the screen to show.
Okay, here we go.
Now we see an MR.
So if you remember, this was the MR case where the Sunday bright blood images showed what looked like a mass here in the right atrium. And when I went to the scanner, actually on some of the other series, you do not see, you see this here, but it looks like a very funny filling defect that doesn't persist on the other images. And you can see some flow-related dephasing right there. And remember that I showed other images showing that there was what looked like a dilated right coronary, and we thought this was a fistula, a large fistula, coronary artery fistula, and just wanted to show up the follow-up case here. This was the follow-up to that, and let me make sure you can see that. Okay, so here was the coronary CT that was just done about an hour ago, and you can see that this does confirm that there's a very large proximal RCA that then winds around here and winds back around, and this is kind of in the location of an SA nodal branch, and then it just drains into the right atrium. So if you weren't on the call last week, I had mentioned that the reason this patient came to attention was that the official worry was for an anomalous pulmonary vein, and I believe what they saw in echo was just some abnormal flow here into the right atrium and thought there was an anomalously draining pulmonary vein. But in fact, it's this large RCA fistula. So this CT confirms that there's no mass. What was a filling defect on the MR was some dephasing from a strange turbulent flow due to the fistula here, the shunt within the right atrium. So I just thought that was a good correlation from last week. So
Yeah.
And let me show another curious case, this one, and let me bring up the window here. Okay, so just curious what people would call this case here. This was just a routine follow-up case of something, and noticing here that starting in the mediastinum, I noticed what I thought was going to turn out to be just a hypertrophied bronchial artery right here in the mediastinum, but you can follow that up, and you can follow it superiorly to the level of the right innominate vein here, and you can follow that down inferiorly. If you look to where it's going, it's not actually branching off the aorta, but it's coming around, and you can follow it into the hilum, and you can follow it up, and it's going to actually connect with the superior pulmonary vein branch right here. So presumably this is a form of a meandering pulmonary vein abnormal pulmonary venous connection here that drains all the way up to the right innominate vein up there. So is that what people would call it? I'll bring up the MIPS here.
Which direction do you think the flow is going?
I really don't know. I don't know which direction it's going. I've never really seen, this type of connection before.
Well, because if the patient had SVC syndrome, then as we've seen lots of times, then you develop those collaterals that can drain straight into the pulmonary veins from systemic veins. But yeah, I've never seen it without that. It is interesting.
Yeah, there was no stenosis. There was no evidence of any sort of compromise that you can see here. So it's just this strange, funny vein that connects the suprapulmonary vein to the right innominate vein.
It's a classic example of a vein of Little.
We're just going to name something after you. I've never seen that before.
I've
Brad,
never had anything named after me.
I have a companion case to go with this. I'll show later, but about this pathways with these systemic to pulmonary venous connections. But yeah, it's. I mean, these. I think we know that these exist at least developmentally, and they usually shut down. But we've seen them open up in patients with SVC syndrome. So for some reason, this one stayed open for whatever reason.
Yeah.
I've not seen that before. That's really cool.
So, okay. Well, I just have one or so more cases. Here's another case that just reading a routine CT noted this case, and you can see that this patient, this is a patient in her 60s. Oh, sorry, I apologize. I do not like this new revision of GoToMeeting, but here is a gated CTA that was just done for follow-up, I believe, of a vascular abnormality in the abdomen. But you can see this patient has had multiple bypass grafts here, but the real finding is down here, and you can see, first of all, that the coronary sinus is very, very dilated, and you can see that they're very tortuous and enlarged portions of the coronaries here. And whenever you see this, you of course think about a coronary fistula, and you can see that follow some of these serpiginous arteries up. And the interesting thing here is that they don't really connect with anything that looks like a left main here. But if you look along the right sinus and the right coronary, you can see what looks like an anomalous left main that then gives off this, this serpiginous set of coronaries that then drains into the coronary sinus and is a fistula. So the draining point is about right there, and it's just interesting that this is an anomalous, presumably left main, with a coronary fistula to the coronary sinus there. So just a very nice.
Left main or right main?
Well, what would be the left main arising right here from the RCA, and then coming back around and giving off. You can see that it's somehow this is giving off the LAD and here from this fistula, and then the circ is given off in here as well. And the cath on this, I don't have the cath images, but it just simply stated that the circ and the LAD arise from different portions of this fistula. So, and strangely, it didn't mention that the origin was anomalous, but it certainly looks anomalous here. So that was just an interesting case.
Okay. Well, thanks, Brett.
Okay. I guess I'll hold the other ones for next time.
Yeah, that sounds great. All righty. Well, if you guys don't mind, let me just show the one case, and if there's time, I'll go back and show this. I want to show this companion case to Brett. Let's see. All right. So this is it. I have to make it show this one. Okay. So this is a lady with severe pulmonary hypertension, and you should see a CT, a large patient. And you'll notice from the get-go, there's a lot of collateral flow. As I scroll through, you will see all of these mediastinal collaterals just kind of dancing around. But what's really cool is this was done for pulmonary embolism. Let's see if I can show the window properly. So there's good contrast coming in the brachiocephalic vein into the SVC. They inject it through a vein, even though there's a central line. But you'll notice there's very poor contrast to pacification of the right heart. We have contrast in the left atrium, and it's asymmetric. We have contrast in the aorta, and really nothing in the pulmonary arteries. The SVC is wide open here, but there's all these collaterals. And so if you follow these pathways here, there's all these tortuous vessels. But what we noticed was right down here is this jet of contrast coming in, maybe another one here, but a jet of contrast coming in the left atrium. If you follow that up, clearly this is a pulmonary vein, but it anastomoses to these mediastinal collaterals. So we've seen this in SVC syndrome, but this patient has a patent SVC. So we postulated that the right heart pressures were so high that blood was taking a different pathway. And indeed, they did a right heart cath the next day. And her right heart pressures are systemic arterial pressures. They're over 100 systolic, and diastolic was about 70 or something like that. So severe pulmonary hypertension. But I have never seen this. And one of our pulmonologists, who's a pulmonary hypertension expert, had asked me if I'd ever seen it. And I know we've seen it. I told him we've seen it in SVC. So this is almost physiologically acting like an SVC syndrome. I don't know. Has anyone ever seen anything crazy?
That's really cool.
I thought so. And that was my best explanation. But I wanted to show it because it's cool. But it reinforces the fact that these systemic to pulmonary venous collaterals channels, we see them open up sometimes. And in this case, it's a functional because of pressure. But we've seen it in SVC syndrome. We've seen it fibrosing mediastinitis and other things that cause these collateral pathways. But I thought these were rather striking. I mean, she's got chest wall collateral. She even has big ones down here along the intercostals, just huge intercostal collaterals.
And are there vessels penetrating the pleura into the left upper lobe, medially, near the mediastinum?
That's a good question.
There's some other funny vessels in those lungs.
Yeah, there are a lot of funny vessels. But it looks like most of them are just dancing around the mediastinum trying to get to the azygos system. And this one here in the left lower lobe is what communicates to the left atrium. And that's why we're seeing all this contrast. I'm sure there's more. You almost get the sense there's maybe some flow coming into the other inferior veins as well. But there was more.
Just keep that window and go a little bit higher to the left upper lobe.
Let's see, the other.
Mediastinal window, go up higher. Keep going.
Like right here,
a little bit more, a little bit higher even, like right there. What is that big fat vein thing right there?
Yeah. I think it's actually in the mediastinum and it's just kind of poking out into the lung. Because if you look at it, it comes back into the mediastinal fat right here. And but
isn't there a vessel next to it that is quite opacified? Or
here?
Right there. That unusually opacified compared to the others?
Yes, that's a good observation. Yeah, there must be a shunt here as well.
Something odd about that, isn't it?
Yes, and then you can see how much contrast is in it. And that's the superior pulmonary vein coming in. But anyway, that was just crazy. So it's a functional SVC syndrome.
Wow.
Why did she have pulmonary hypertension?
Nobody.
I missed it.
She's considered idiopathic.
Huh.
Something.
Yeah, I tried to get her right heart cath numbers directly, but there was an issue with the Citrix thing today. But yeah, she's got systemic pressures. Now, I think there's one thought is she has her liver's not normal, and so they think she might have some early NASH. So the question, to me, I think it's pulmonary hypertension's her bigger problem and probably was there first, and this may be secondary. She's also diabetic and all that, but it's possible too. And apparently, there's not necessarily a direct correlation with the severity of liver disease and the pulmonary hypertension. Even just a little bit may be enough in some patients. But I've never seen this many collaterals like this just from pH, so it was impressive. All right, I'll let someone else go. I just wanted to show that one before we ran out of time. Howard, you were gone last week. You want to show some cases?
Okay. This one is really just something we've seen before, but it's just really a challenge and just reinforces the challenge of seeing a case of tumor in a patient with interstitial fibrosis. So looking at a case like this, all of us would describe findings consistent with a fibrosing lung disorder. And, Travis showed a case, I think, a couple weeks ago where an opacity turned out to be a cancer. So here is the cancer in this patient. It's really hard to see. It's right near the diaphragm. It's in the middle lobe. It's a little bit rounded there, but as you might imagine, it's really easy to go by that. So here is sorry, scrolling that fast. The patient does have that tumor and FDG avid regional lymph nodes consistent with metastases. So adenocarcinoma in the context of a fibrosing lung disorder for that case.
Howard, a primary lung cancer, you think?
Yes, that's what is the diagnosis. Or they got adenocarcinoma from that lesion there. So presumably that, yes. This is just a funny case of a patient who's a trauma patient, and we see the usual things in a trauma patient, and you're reading radiographs, and then after a few days, you see an image like this, and I will tell you I went right by that. And I think it's because when we see funny things that shouldn't be there, your brain basically tends to dismiss it, is my theory. So if a certain object is there, we just assume it's extraneous, not related to the patient. So here is the object in this person, and that's the finding. But of course, that was there the next day and was a new finding, and that turned out to be a tongue ring that had been displaced from his tongue in the ICU, presumably from all the tubes that he has. So that's not in the airway, but it's in the esophagus, and this image kind of shows it there from the endoscopy. So that's just a cute tongue ring displaced into the esophagus during an ICU stay. This one is the one that I sent out today, and I just want to show this one really quickly again. So this was an unanticipated finding in a person that had a history of parathyroid adenomas, and he had hypocalcemia again, and I think the CT was obtained in that context. So these findings that I'm showing you here were unanticipated, but then we did get a history that he had a prior CT some years ago, and as best we can tell, these were definitely there, described as such. And I've seen a couple of cases like this, and I'm impressed by the fact that we have pretty substantial bronchiectasis, and yet, unlike the usual bronchiectasis, we don't have the thickened, inflamed bronchial walls. And it's pretty dramatic degree of bronchiectasis, and in some places like that, there are cystic changes that are quite round in contact with the bronchiectasis. So I've seen a few cases like that, and my theory is that this is pretty suggestive of Sjogren's syndrome. And I don't know why some people have very conspicuous bronchial dilatation in addition to cystic lung disease.
What about Monier-Kuhn?
What about Williams-Campbell syndrome?
No, that's peripheral.
No, I mean, Williams-Campbell's mid-order bronchiectasis. I would think that this is Williams-Campbell syndrome.
Me too.
Yes.
I'd vote for that.
Look at the size of that right main stem bronchus. That thing is absolutely massive. I don't know.
It's plump.
Don't you think that in all of the causes of bronchiectasis, particularly with mucus production and inflammation and so on, it's unusual to see bronchi this dilated, where the wall of the bronchus is seemingly not there or imperceptible, or another very, very thin?
Howard, that's what's so good about Williams-Campbell, because instead of being dilation caused by inflammation, which is going to cause thickening along the way, it's a structural abnormality of the bronchus that lets it dilate. It doesn't have to be infected, therefore it doesn't have to get thick.
Doesn't have to get thick.
Well, the same is true with Monier-Kuhn, but Williams-Campbell people are usually pretty sick. I mean, they're usually diagnosed really early in infancy.
Well, that's what the literature says, but we've seen several cases in adults as incidental findings, often called emphysema or something. The only other thing, though, Howard, is it's usually a cylindrical bronchitis. Some of these airways go almost all the way to the pleural surface, which would be unusual for a Williams-Campbell. It's usually like 4th through 6th order. You've got some like right there in that right posterior upper lobe. You've got some going out pretty far, which would go against that.
Yeah.
Is there any, some of the cases of Williams-Campbell syndrome appearance with the middle bronchiectasis have been caused by prior adenoviral infection or other viral pneumonias. Does this patient have any history of that?
I don't have a history of anything that I could find, anything related to the respiratory tract at all in terms of symptoms. Nothing.
Brent, I just wonder if those cases are ones that came to attention because of the adenovirus infection. Then they imaged the person, and it turns out the person had an underlying Williams-Campbell that was unrelated. So
Yeah,
just if that's a bias in terms of detection.
But it's biased the other way. How are you determining it's Williams-Campbell? Is it you actually getting path to show that there's specific elastic fibers that are absent, or are you just assuming because it looks like it is? Because a lot of these people, they just see it and they don't actually wedge out a chunk of lung to look at their bronchi.
That's
right.
true.
Yeah. But I guess I'm just feeling that the cases that have been billed as Williams-Campbell, many of them look just like this in the literature. So it's unlikely that all those are path proven. But
right.
Yeah. I think my speculation is that, if I'm right about this, because I've got several cases of this in patients with definite Sjogren's syndrome, that some of the cases that are billed as Williams-Campbell, just because it looks like Williams-Campbell, are not. And this is some really weird form of that disease.
Yeah. No, it's just like with any tracheal thing. Like with Mornier-Kuhn, no one ever, it's just if you have a massive trachea, you just assume it's tracheobronchomegaly. No one's actually biopsying the trachea and looking for the deficient fibers. And the same thing with Williams-Campbell. I mean, the ones I've seen that are where they've done all that stuff are, again, the little kids who are just deathly sick. And those are the ones I know have path proof. Because, anyways.
Yeah. Just for comparison, I'll show you this case, which is different. But this person is known to have Sjogren's syndrome. And you'll see, in addition to the cystic spaces, the bronchiectasis that I just showed you, there are also foci that we assume may represent foci of LIP. But I looked at this, and it looks almost identical to the one I just showed you. And I've got a few like this. That's why I started thinking, I wonder if this kind of bronchiectasis may occur in Sjogren's syndrome. It's so interesting how dilated those bronchi are, but in many areas you can see an inflamed, thickened wall. So, just by speculation, I'm really impressed by it.
Young amyloid?
Pardon?
Are we assuming that all the calcified amorphous material is amyloid or amyloid deposits?
I think that my idea is that the cystic spaces, be they parenchymal cysts or, if I'm right, dilated airways, are the result of elastolysis from deposition of protein, light chains. Yeah.
Oh, no, I'm saying the calcified stuff, those calcified amorphous kind of nodular areas. Do you think that's also that you
I don't
see?
know. On my screen, they don't look that high attenuating. I think these you ought to find patchy nodules and ground glass, you mean, right there. I don't know, just my speculation that I think I've seen a number of cases and I've been trying to collect them, and I'll let you know if ever I find out anything interesting about these patients. So I've shown you those. Yep, that's it, Jeff.
All right, thanks, Howard. All right, Travis, you want to show some, or Seth?
Let Seth go.
All right.
All right, so I have three cases that all have path proof, so there's no deliberation of what they are. This was a guy who jumped off a bridge and fell 50 feet and hit the pavement. And he has this, it's interesting, it was initially missed on the initial trauma study, and I'll include that. But it was subtle in there, although it was smaller, and it has gotten bigger since on the subsequent study. And he has this defect in the aorta near the root. It's above the sinotubular junction. I was debating whether or not it was just an incidental sinus of Valsalva aneurysm, but it's above the sinus. And the thing that convinced me that it was an actual kind of contained rupture of the root, a traumatic contained rupture of the root, was he actually had, I'll just show it, his trauma study, which showed that there was blood in the pericardium. So, you know, most people with this kind of traumatic aortic root injury, so this here, all in here is high density and is blood. And so people with this, and you can see it's smaller and it's subtle. So most people with aortic root injury like this don't make it to the hospital. They die pretty quickly. And it's the first case I've seen. Charlie has said he's seen some other cases, but it's the first case I've seen of, and he went to surgery and they fixed it. And there was supposedly a tear there. So this is you know, we most commonly see them by the ligamentum because they often survive at that location or may survive at this location. But this is the one at the root. And this one, unfortunately, what?
I was just saying that's impressive.
Very impressive.
Yeah, they usually. I was arguing with Charlie forever about it, saying, yeah, it's got to be an incidental sinus of Valsalva aneurysm, but it doesn't arise there. And then when I saw the blood in the pericardium, and then he went to surgery and they confirmed it. So.
Yeah, the blood in the pericardium is. Sometimes people try and just, I don't know, ignore hemopericardium, but it always scares the heck out of me. It's like subarachnoid hemorrhage. So even if that's the only thing you see, then you look closely.
Yeah. I assumed everyone with that initially just exsanguinated immediately, but I guess not everybody. And this is, unfortunately, the guy has an outside MR, and we don't have it, and it shows characteristic findings of it, supposedly, because I have the report. So this person comes with this, it's a woman, pretty much asymptomatic, incidental finding on a chest radiograph, which I'll have to include the images of. You can see there's this lesion here. They thought it was going to be a neurofibroma or schwannoma neurofibroma, biopsied it, got some weird stuff, mostly inflammation. They resected it, and this was hyaline vascular variant of Castleman disease rising from the chest wall. It almost looked like it's coming from that joint here between the kind of the rib and the sternum or manubrium, but it was not. So, and the MRI talked about just dramatic enhancement and all this stuff. So I'm trying to get a copy of that, but it's a case of Castleman disease, which we don't see a lot of. And
you think it's just an internal memory node?
Oh, that's a good thought. That's actually, you know what? That's actually a very good thought, because they are nodal, and they do arise from nodes, and that's a good location for a node, and that's actually a much better thought than the wall that I was told. They said it was a chest wall thing, but you're right. It's probably an IM node.
You wonder if it's just been there for a while and it remodeled the inner table of the sternum near that sternoclavicular joint.
Yeah, I'll talk to her. No, I think you're absolutely right, because that's where they should. I mean, it's one node that just becomes massive in most cases of centric. So that would make much more sense than a chest wall. Even though we have seen chest wall lesions, that just makes much more sense. I'll talk to our surgeons and see if it was. I'll see them tomorrow. See if it was attached along the internal mammary chain, because that is good. And this one is unfortunately, I have to show you the. I only have JPEGs. It's just a pretty case. This is a guy. This is one of our people from Israel brought this, and it was a guy who presented. Fortunately, the JPEGs I was given weren't that great. I try to create these movies, but a very ugly, loculated pleural thickening, which itself is not that impressive. The lungs themselves are not that impressive either. But the kind of hint is this somewhat calcified lesion in the liver, and the coronals just show the same thing. But this is the movie of the when they went in, and there's like 30 minutes of this. This is all kind of caucus. So somehow it's just awful looking. And you can see how ugly and thickened the pleura is. So this was iconicoccus that I guess went from the liver into the pleural space through some sort of from diaphragmatic defect or something. I don't know, or it got there some other way. I don't have much experience with this, with the conococcus, but you know, he definitely has a liver lesion, which was known, and the theory was that it kind of went through the liver through the some sort of diaphragmatic defect and seeded the pleura.
Yeah.
You can get either. You can get hematogenous dissemination, but I agree. The fact that this is on the right side and it's contiguous with that calcified
yeah, it's like
liver
right by that thing there. Yeah. So, but he just showed us the video, and it made me realize why I went into radiology and not surgery. That's pretty awful looking.
Remember, it is lunchtime where David and I are right now too. So.
Excellent. It's like cottage cheese. All right, those are my cases.
Right.
And I'll send these images. I'll actually ask the guy, make sure it's okay. There's nothing here but the images, but I'll ask him, and right. I'll send those along.
Cool. All right.
Thank you.
Travis or David?
Sure.
I can show one or two.
Okay. We'll let David go.
Okay, do we see a CT scan?
We do.
Good.
Okay, so this person has a whole set of ill-defined lung nodules that are worse in the bases and has had them slowly worsening, with some lesions actually regressing, others arriving, but overall worsening over about 4 years. And this is similar to a case that Jonathan Chung showed 5 years ago in 2011. This person has a congenital syndrome called Kabuki syndrome, and there are a lot of developmental anomalies that go along with that. And there's a common association with an immune deficiency of immune globulins and clinical CVID, so it's common variable immune deficiency. And the case that Jonathan had also had lung nodules, but not as many as this person has. And this is presumably in the setting of the CVID is ILD, granulomatous lymphocytic interstitial lung disease.
Is the spleen
so big? The spleen is big in this person.
Okay.
And let me give you a better window here. The spleen is big, the liver is big, and there was an intestinal malrotation as part of this syndrome. So Kabuki syndrome with CVID and this slowly progressive nodular lung disease with some lesions regressing, consistent with GL-ILD. So there's some nice articles about this, and so similar pictures in this article from 2008 with these blobs worse in the bases, bigger blob up here in the apex in this person, but pretty characteristic findings. And there was some modest mediastinal lymphadenopathy here too, not tremendous, but definitely more than normal. So that all goes along nicely with the GL-ILD. So yet another case of Kabuki syndrome. This is better than Jonathan's. I wonder if it was the same person that migrated from Denver to Seattle, but the age is different. But as similar to his case, a young woman. So let me show you this other one. Here's a person who had came in with a spontaneous pneumothorax. Here we go. So you can see that the left lung is completely collapsed. This is a 23-year-old woman at this time, and she has a pneumothorax. They treated her with chest tube. Things got better. Here the pneumothorax has been reduced, and then she had a CT scan. So here's the CT scan with still some pneumothorax. The drain is still in place. And then we come into this bubbly left upper lobe lesion here that has a sharp posterior boundary to it. And there was no mucus plug associated with this. And this is the most common location for what used to be called congenital lobar emphysema, which doesn't have to be lobar, it can be segmental, now called congenital lobar overinflation. So I believe that this bubbly lesion here is the cause of her pneumothorax. The pulmonary note said that this can't be congenital lobar emphysema because that always presents in infancy, but we've seen a number of cases in adults as incidental findings sometimes on CT scans. In this person, it's not incidental. It caused pneumothorax, and it will probably cause pneumothorax again unless she has this part resected. So I expect that if she does get a resection, this will pan out to be congenital lobar emphysema, now called congenital lobar overinflation. And let me show you this this person here who has the most impressive calcinosis, soft tissue calcinosis that I think I've seen. It involves the chest and the abdomen. You don't get a picture for how bad the abdomen is here, but I'll show you CT scan later. Also involves the arms. This person's background is scleroderma with a myositis component. So this is soft tissue calcinosis. This person is unable to get the arms up all the way because the skin is so thick and stiff. And you can see the massive amounts of stuff back here. Here's some of the abdominal component down here, anterior and posterior. And let me show you CT on this person, because I know you don't believe me. Here is a lot of soft tissue calcification, and this is much worse than it was in 2012, 2013, so this has progressed dramatically over the years. And then we get down to the abdomen. I think we've got abdomen farther down. There's quite a bit in the abdominal wall, and it's really heavy around the pelvis. Now, in terms of physiology, this person has declining pulmonary function tests with severe restriction at this point. The restriction is much worse than it used to be. And look what's happening to the diaphragm. The diaphragm is gross. The crura of the diaphragm here are grossly hypertrophied. So this looks like some cases of weightlifters that I've seen. So this diaphragm is having to work against the rigid abdominal wall, which doesn't give way when the person tries to take in a breath. So a normal person relaxes abdominal muscles. That allows the diaphragm to go down and the abdomen to pooch out so the person can take in a breath. Here the diaphragm is having to work against an abdomen that does not relax. And therefore the diaphragm has to push down into the abdomen really hard, and it has hypertrophied. On the old CT scans from 2012, we didn't have this degree of diaphragm hypertrophy. We already had a little calcification and probably a little skin rigidity already, but nowhere near this degree of hypertrophy 4 years ago. So I've seen this in some weightlifters. They get hypertrophy of the cruise too, and it's because they force themselves to breathe in against, when they tense their abdominal muscles, they tense their core muscles. That keeps their abdomen from pooching out, and then they try to breathe in against that. And this is a common maneuver in weightlifters do, and I've seen a number of weightlifters who get hypertrophy like this. And remember about a year ago or a year and a half ago, one of the participants here sent a case to Jeff, I think, or may have shown it himself, of diaphragm hypertrophy in a person who was did a lot of yoga.
Yeah, it was.
So
Vargas sent a case and did some of the.
That was Blake.
Oh, was it Blake?
Yeah.
Okay, but it was intense, intense breathing.
Right. But you have to breathe. You have to breathe in against resistance, and the resistance, the important resistance, is the abdomen.
Right.
So.
And I thought in Blake's case, the guy did a lot of like upside down, prolonged hands, or handstands or sitting positions. Some crazy upside down stuff.
Some like intense breathing stuff, where you would you do rapid contractions of the belly to pull in the diaphragm, rapid ventilation. So that would make sense.
Wow.
That's
Greg Kitchell, my colleague, was a weightlifter. He used to lift weights in the same studio that had the guy that played the Incredible Hulk. So that was one of his weightlifting buddies, and he described there's a name for what weightlifters do, but it consists, I think, of the same sort of thing: rapid inhalations against a tensed abdominal wall, a tense core muscle, or something like that. So maybe similar to what the yoga guy was doing.
How do you not know Lou Ferrigno's name? So disappointing.
I'm sorry, what?
So how do you not know Lou Ferrigno's name? Incredible Hulk.
Because
I'm just joking.
Because I'm culturally isolated. This conference is my only social life, guys.
Great case. Wow.
Yes,
those are my.
Thanks, Dave. All right, Travis. We got about 10.
Okay, Yeah, I'll show one,
Okay.
and then Jeff, if you have some, I mean, I've got a couple I can show, but I can also
You've
hand
got
off.
time. Go ahead.
I'm going to reorder things. This is a case we've seen before, but I think it's very interesting, and there's some good physiology in this case. So this is the calcium score, and I'll get back to the history of this guy in a second. You can see he's got really dilated coronary arteries, and one of the reasons I show you the calcium score is to show you that there's a little bit of calcification of his papillary muscles and a little bit of subendocardial fat deposition in his LAD territory, and we see tons of collaterals on this side. So I'm showing this one first because it's similar but different from what Brent showed with the coronary fistula. And in this case, you can actually see that this guy has Al Kappa. He's in his 40s, and the story, and I have it in the history that I'll show you in a second, is he presented with signs of a sinus infection. They did an EKG, which was abnormal, which led to a stress test, which led to all of this other stuff. But apparently he's very active and works out, and he has even run a marathon before this study, which, we've seen a couple of cases of Al Kappa presenting in adulthood, but this is certainly the most impressive case I've seen, the fact that this guy is asymptomatic into adulthood. Didn't have any other abnormalities associated with this, but I think that he's definitely had some demand ischemia and probably some small infarcts in his LAD territory, given that he's got already this little fat deposition and the calcification along the papillary muscles. I think what's cool about this, though, is showing the timing bolus of the CT, because you can see the physiology here, that you know that there's a left to right shunt because the pulmonary artery is full of contrast. We don't have any contrast in the aorta yet. You see this puff of non-opacified blood, which is presumably coming from his left coronary artery, this steal phenomenon in that direction. And then even on the CT, you can see the same thing where you have this little puff of higher attenuation contrast coming into the main PA right there. So I just thought it was a really cool, a cool example of our flow-related phenomenon that we often see that include a physiology.
Look at all the little vessels coursing through his myocardium. It's so.
I know. Yeah.
It's so odd. I mean, there's just tons of these little vessels coursing through there. That's really.
Yeah, and so they treated him with just a ligation and reimplantation of his left coronary artery.
And he did okay?
Yeah.
Oh, that's awesome. We had a patient that they did that to, was 60, and she died like the next day.
Now this is a case I found that one of my colleagues here showed me. It's from a while ago here at UCSF, but the other case I showed, and I think it was you, Seth, that had commented on, it was a patient when I was at Emory, and Brent probably remembers this one too, that had Al Kappa, but also had, I think it was an proximal interruption of the pulmonary artery, which the theory was the combination of the two elevated the pulmonary pressures and probably reduced the degree of steal. But this guy has none of that. I'll try and get the cath. It's hard for us to get caths, but I'd like to see all these little septal perforators, especially because it almost looked like more of this sawtooth septum, like you sometimes see with just trabeculation. But yeah, I think. But
even look at the lateral segments. I mean, there's tons of little vessels that almost look like they're being directly fed from these large vessels, just kind of feeding them. I've not seen that before. That's interesting.
Yeah. So the combination of all of these findings, and again, as you know, I like seeing these little flow-related phenomena when we can explain them.
Excellent.
All right, this one is one I saw recently, and the imaging is interesting, but it's not as interesting as the story. So this lady, I think she's 34. She's in her mid-30s here. And you can see she's got a port. She's also had a right mastectomy. She's had a right axillary lymph node dissection. And this study was in June. This was at an outside hospital. And you can see she's got a left infrahilar mass. She's got volume loss on this side. And the volume loss is a little more subtle on the lateral view. I'll show you the subsequent CTs. You can see part of this mass here. At this point, I think she has partial left lower lobe collapse. I'll show you the CT, a series of CTs here. And here, this is a month later, and you can see now that she's got just perilymphatic disease throughout her entire left or right lung. and then this large mass here obstructing her left lower lobe bronchus. So this was confirmed to be recurrent metastatic breast cancer. But what's remarkable about this case is that she was originally diagnosed when she was 11 years old with breast cancer. And she had a rare type of breast cancer called secretory carcinoma, which has also been referred to as juvenile breast cancer or juvenile carcinoma, which has been, there are case reports of it occurring in kids. I'd never seen an 11-year-old with breast cancer. And furthermore, she had gone for 20 years without a recurrence. And this was the site of recurrence. These are usually triple negative, hormone insensitive tumors. So that was July. And then she got this next CT. I think this is the one. This is the one, because I saw her one a couple days ago. This was last month. So by August, you can see she's got widespread lymphangitic disease throughout the right hemithorax. She's got some nodules on the left, and then this enlarging mass obstructing her left lower lobe bronchus. So they put her on some experimental chemotherapy. I don't know what it is, but this was last week, or a couple days ago. So this was in the course of a month that this entire thing disappeared. Or almost entirely disappeared. She's still got a little bit of residual disease. But number one, I've never heard of this secretory carcinoma before. That it can occur in children, including male children, and that usually has a favorable prognosis. And in this case, whatever chemotherapy they gave her worked, at least for now.
So
this is a case report.
Some particular directed new antibody or something like that, or some receptor.
Yeah. Yes, it was. She's on a clinical trial. I don't even know. I don't think she was randomized to the placebo though, based on this. Right. Based on this response. But it was confirmed recurrence. They biopsied her. This was another case, not the same person, but this was another 11-year-old. And it's not the best case report, but it at least describes a little bit of this secretory carcinoma. So I thought that was very interesting. And then, Jeff, can I show one more? All right, I'm going to show one more.
Sorry, my microphone.
Yeah. Oh, this one is I don't know. I don't have an answer yet. Hopefully we will get an answer. This is a guy who is, let's see how old. He's 43. And he had an atrial septal defect repair as a kid. You can see I think he's got sternotomy wires here, yeah. And so this was done last October as a pre-AFib ablation, just left atrial mapping. What wasn't noticed at the time was this mass underneath of his left pectoralis muscle, because it wasn't, and apparently he wasn't reporting that he could feel this at the time. You can see it there. I'll show you the post-contrast, and then I'll show you it has a lot of arterial enhancement, some areas that are less enhancing. And then this came to my attention because he got a subsequent CT. I don't even remember why he got this CT. It may have been for mass. But this is the CT from this summer, and then he had a follow-up abdomen and pelvis CT, which was non-contrast. And I guess my question is, what do you guys think this is? Because you can see it's not calcification. It is heterogeneously enhancing. I was wondering if it could be something like a hemangioma. It's a little weird with the enhancement pattern. He does have a history of hypertension. I don't know if it could be a paraganglioma. But I was kind of at a loss of what this was. You know,
I'm sorry. Where is it? Oh.
Yeah. And it's unchanged in size from this left atrial mapping CT a year ago.
Castman disease?
Yeah.
Yeah.
Island vascular.
Wow.
Is it calcified or is it enhancing? Do we know?
No, it's not calcified. See, that's why I showed this is an abdomen pelvis CT done more recently. And then Seth, I've got an MR that shows it. You know, it's kind of a.
How bright is it on T2?
Unfortunately, we didn't get a great T2. You can see the enhancement there, but let's see. Really, all I've got are these SSFPs, and it's kind of right at the edge of the field of view.
Yeah,
I was wondering. Yeah, I think they probably need to take it out. I don't know if anybody's ever seen a paraganglioma in a location like that, but
it should. I mean, theoretically, they shouldn't occur there. It's not along the ganglia that. So they technically shouldn't occur there, but it could be hemangioma. If you showed it to me in the heart, I'd say it could be hemangioma. But that's cool.
Yeah, I don't know. We'll see.
All right.
But
Yeah.
I'll keep an eye on this one and let you guys know.
All right. Thanks, everybody.
Thanks, guys.
Bye-bye.
Thanks, guys.
Bye.
See you next week.